separate and exclusive super specialty department of pediatric orthopedics dedicated to the care of musculoskeletal problems in children up to 18 years of age. The department was formally inaugurated on 9th of August 2016 by then Honorable Vice Chancellor Professor Ravi Kant with Professor Ajay Singh sir as its head. The department has a vision to achieve academic excellence in the field of pediatric orthopedics, to provide state-of-art quality healthcare in a cost-effective way, and to be the leader in research pertaining to pediatric orthopedics. So now, without any further delay, let us begin with the program. I request Professor Najmul Huda sir, Professor and Head Department of Orthopedics, GIMS, to present his talk on evolution of pediatric orthopedics.
नहीं फैसल का फेस तो इसको हटा दो. हाँ ऐसे कर दो या तो. हाँ ये ऊपर वाली हटा दो. ये इस पे रिलीज नहीं है तुम्हारे पास इस पे नहीं आ रहा है. Good morning, everyone. I really feel privileged to be here on the occasion of the first foundation day of the department, of which I was a faculty member though for a very short time, but yes, I was present at a time when the Department of Paediatric Orthopedics was taking baby steps, and I have been a witness to the establishment of this department, and therefore I always feel a part of this department, and I'm really thankful to Professor Vikas Verma and all the faculty members of this department who gave me this opportunity to come here and deliver a lecture on evolution of pediatric orthopedics in India. So the association between orthopedics and pediatrics is an ancient one. In fact, the word orthopedics, which was coined by a French priest turned physician, Nicolas Andri, is an amalgamation of two words, orthos meaning straight and pedion meaning children. So basically this word was coined to deal with the prevention and treatment of deformities in children. So orthopedics as a specialty started with treatment of deformities in the children. So it is as old as ancient history. In his book Law Orthopedy, which he published in 1741, this was a book in 2 volumes, and he specifically says that orthopedics is the art of preventing and correcting deformities in children. So orthopedics has always been associated with pediatric population, with children, and in the first volume of the book we find references of deformities like torticollis, scoliosis, knock knees, rickets and club feet. So the start of orthopedics was actually from children. So pediatric orthopedics is a term which is not new to us, and this is now a upcoming and a very much established subspecialty, I should say now a super specialty in orthopedics, and more and more younger surgeons are opting for this field of orthopedics to provide their services. So why are we talking about pediatric orthopedics? Basically as a branch of medicine, it is it helps to diagnose and treat the musculoskeletal conditions in the pediatric age group and adolescents. The bone health and the needs of children is unique because every child has to grow. The bones, they go through a period of growth and development, and hence each phase of growth and development is unique, and the needs of the children are also different. So a pediatric orthopedic surgeon helps in early detection and intervention of various conditions which, if not addressed on time, will lead to permanent disabilities. For example, if we take the example of clubfoot, if not diagnosed and treated at the right time, this might lead to a permanent deformity to an individual, and this will not only have implications on that patient but also to the family, the society and the nation at large. Because pediatric orthopedics deals with the different growth phases of the children, a pediatric orthopedic surgeon is trained enough to identify those unique needs and allows them to provide age-appropriate treatment options. Again, I would cite the example of a simple case of genu varum or genu valgum, an angular deformity around the knee, say for example. एक पेशेंट 2 साल का बच्चा अगर हमारे पास 1 साल का बच्चा ओपीडी में आएगा विद bowing of the legs, so the treatment will be different. But a same child who's coming to us at the age of 5 years, at the age of 8 years, at the age of 10 years, or maybe a patient, a girl who has achieved her menarche, reporting to us with varus or varum at 13 years of age, the treatment has to be different. So that is why the understanding of these diseases which need age-appropriate treatment, similar is the case with DDH, is very important, and hence the importance of this subspecialty of orthopedics. Children are to play. They have an inherent quality or a virtue or a desire of every child is to play with his peers, with his group. Imagine a child who is suffering from a deformity, orthopedic disability, who is not able to play with or interact with his or her peers. This will lead to a lot of psychological impact, and by addressing the concerns of this child, an orthopedic surgeon can participate, can motivate that child or treat that child to the fullest potential, so that he or she can participate in the physical activities. So why pediatric orthopedics for that matter? If we look at the statistics, the census of 2011 says that 39% of the population, Indian population, is less than 18 years of age. The UNICEF data of 2023 says that there are 436 million children amongst the Indian population. 2024, 1/4, 25% of the Indian population is less than 18 years. So that is a sizable number. So these numbers are important to realize that because we are having these many, almost 25% of the population is of pediatric age group. So definitely these must be having health related issues which need to be addressed. If we look at the disability census, 1.2 million children less than 5 years had a disability, and of these 20% of these disabled children or people are having locomotor disabilities, and locomotor disabilities by and large a major share is dealt with by the pediatric orthopedic surgeon. So that is the magnitude and understanding of the importance of this branch of this subspecialty of orthopedics. So the average patient attendance these days in any pediatric orthopedic OPD is between 200 to 300. This I am talking about at a busy pediatric orthopedic OPD center like KGMU, but variations occur according to the place. And at the moment, centers having exclusively pediatric orthopedic departments are very few. To name them, KGMU is one of them, CMC Vellore, KMC Manipal and PGICH Noida. So there are only these 4 centers in the entire country which have a dedicated pediatric orthopedic department. Though there are many other centers which do provide pediatric orthopedic services by developing pediatric ortho clinics or units, and there are many, and to name a few, it is CNBC, AMU, Kokilaben Dhirubhai Ambani Hospital, Sir Ganga Ram Hospital, Delhi, Apollo Children's Hospital, Chennai, PD Hinduja Hospital, Mumbai, and Wadia Children Hospital. So these, and there are many more which do provide orthopedic services as a unit or as clinics. Now this is the current scenario. Now let us see how all these things happened. Let us go back in the history and try to see how pediatric orthopedics has been evolving during this time. So if we look at the early developments, that is in the pre-independent India, at that time pediatric orthopedics was never heard of, because whatever orthopedics was being done was done by general surgeons. The orthopedics as a specialty was almost non-existent in the pre-independent India. Okay, the orthopedic conditions were usually treated by general surgeons, and there were lack of resources, lack of knowledge. Therefore, congenital deformities and pediatric musculoskeletal conditions, they were not always treated optimally. The early pioneers of orthopedics, and apart some way pediatric orthopedics, included Dr. M.G. Kinney and Dr. R.G. Katrak. Dr. R.G. Katrak was the second Indian to do his MCH orthopedics in Liverpool. He was trained with Professor T.P. McMurray, and he came back to India and started practicing exclusive orthopedics. This thing was really unheard of at that point of time. All the orthopedics was being treated by general surgeons. There were no dedicated orthopedic specialists. But he came back because he had done MCH orth, and he started practicing orthopedics and started a first specialized orthopedic unit in 1936 in the Wadia Children Hospital. And he was the person who developed a dedicated orthopedic department at KEM Hospital and Medical College in 1942. So this is how the birth of orthopedics happened in pre-independent India. Later on, there was after independence, there was people realized the need to have good institutions providing health care, and therefore there were many colleges and institutions they were opened up, and the thrust was to improve the health care delivery in the country. So specialized orthopedic departments were set up in various medical colleges. Pediatric orthopedic clinics were started taking the baby steps, but not actually, it was in its infancy. Professor Dr. Katrak, Professor Balu Sankaran and Dr. K.T. Dholakia, they at that time they practiced closed or open reduction of DDH. It was the polio epidemic and the resulting post-polio residual paralysis that actually made everyone realize the need for specialized pediatric orthopedic care. At that time, pediatric orthopedics was synonymous with treating polio, and because the PPRP was a sizable population, and hence the need was felt to develop centers which were able to provide specialized care to these polio patients. Dr. P.K. Doraiswamy, Dr. N.S. Narsimha Rao, they contributed significantly to the development of this subspecialty, and AIIMS and CMC Vellore, they became centers for the management of PPRP. In the next decade, pediatric orthopedics was started to be recognized as a specialized field, and there were the dedicated departments of orthopedics in major institutions like AIIMS and other institutes of national importance. Surgeons like Dr. Bhatia, Dr. Dhamija and many other, they contributed to the development of pediatric orthopedic care and laid the groundwork for this specialty in the country. Many training programs were being organized for pediatric orthopedic surgeons. I would say orthopedic surgeons who were trained to treat conditions like clubfoot, cerebral palsy, DDH and scoliosis. 1970s, Professor Robert Salter, he visited Delhi in the early 1970s, and at that time he spoke on CDH and exposed the orthopedic surgeons to the management principles involved in DDH. Dr. V. Chako of Manipal, Professor K. Sriram, who was trained in UK, and Professor Arun Goyal, who was trained in Liverpool, they all started performing open reduction with Salter's osteotomy. So though they were practicing adult orthopedics, but these are the pioneer surgeons who actually established the need and the trend of doing surgeries on pediatric conditions as well. In the 1980s and to 1990s, Dr. P.K. Sethi and Dr. T.S. Sriram, they introduced model techniques for managing congenital deformities, and Dr. Benjamin Joseph, who was trained under Dr. V. Chako at Manipal, he took over his legacy and continued with that. Around the same time, Professor Ashok Johri, he started doing open reduction, femoral shortening and internal fixation to avoid the ill effects of forceful reduction during DDH, open reduction of DDH, and he published his results with good outcomes. In the 1990s and early 2000s, we had many diagnostic techniques like X-rays, CT scans and MRIs were though not very easily available, but yes, they were widely available and they helped in making an early and accurate diagnosis. And many orthopedic surgeons, there were conferences being organized, orthopedic surgeons were visiting many international conferences to gain training, knowledge, expertise and an insight into various innovative techniques of managing pediatric orthopedics. And there was an surge of interest in the management of clubfoot and DDH. There were many collaborations with international organizations that helped raise awareness and foster a culture of continuous learning in this field. 1990s, we came to know about the very early 1990s, we came to know about the Ponseti casting. This was not a very well, most of the surgeons were not very well aware about this. It was only in 1996 when Sir Ignacio Ponseti, he published his book that this technique was popularized. And after the coming of internet in 2000, it spread widely, and the first workshop of Ponseti casting in India was conducted in 2003 by Dr. Shafiq Pirani. This was the time when I had already completed my MS. So after that, I also attended certain workshops which were being organized by IOA and other academic bodies on this technique. By 2009, many national and state governments, even UP government, they started their Ponseti clubfoot clinics in various institutions, and many workshops were being organized by IOA and Paediatric Orthopedic Society of India. Around the same time, something was going on, and let us now look at the turn of events which led to the birth of a separate Paediatric Orthopedic Society of India. So modern day pediatric orthopedics is basically the work of Professor Johari and Professor Benjamin Joseph. Professor Johari joined the Children's Orthopedic Hospital in 1980, which is located in Mumbai, under the dynamic leadership of Dr. P.K. Mullah Feroz. She was a war veteran and the first lady orthopedic surgeon in India, with a very keen interest in managing patients of cerebral palsy. Initially, Children's Orthopedic Hospital dealt with only polio, and hence it had become synonymous and was known as a polio hospital. But it also dealt with other pediatric orthopedic conditions. On 1st January 1969, COH got a fully staffed CP unit. So there was a separate CP unit, and it was the first of its kind in India and Southeast Asia, and became a model institution where CP children from all corners got the best of the treatment. And this was only possible because of the dynamic leadership of Dr. Mullah Feroz. Now COH is known as the SRCC Children's Hospital and is managed by Narayana Health. Everybody knows about this great man, Professor Johari, who actually got inclined to pediatric orthopedics while working under Dr. Mullah Feroz at Children's Orthopedic Hospital. And during his brief stint at COH, he just came across an advertisement which was published in the Indian Journal of Orthopedics, an advertisement regarding pediatric orthopedic fellowship in Japan. He immediately grabbed that opportunity. He applied for it. He was selected for that. He went to Japan, completed his fellowship, and then he came back in 1986 and started. At that time, there were many people who actually dissuaded him, many orthopedic surgeons who dissuaded him not to practice exclusive pediatric orthopedics. But he came back and started the first pediatric orthopedic unit with weekly OPD at the Sion Hospital under the dynamic leadership of Professor N.S. Lord, who was at the time the HOD of that department. And in 1987, he shifted to Wadia Children's Hospital. The Wadia Children's Hospital was actually started by Kurso Wadia and Nes Wadia, and this hospital was basically became an epicenter of pediatric orthopedics in central India. Dr. Benjamin Joseph did his MBBS from CMC Vellore, MS from KMC Manipal, had a thesis on clubfoot. He underwent a fellowship under J.W. Sherrard, and special interest. His work in Perthes disease is not new to us. We know the amount of work he has done in Perthes disease. He says that at a time he was having 6,200 x-rays he was maintaining. At that time, and even today, record keeping is a difficult task, but he was able to maintain 6,200 x-rays of all his patients, and he published his work and became a name in Perthes disease. Numerous discussions in the early 1990s. Dr. Johari and Dr. Benjamin Joseph, they got together and they held numerous discussions about having an academic society, an academic body dedicated to pediatric orthopedics, so that this subspecialty of orthopedics can have a platform where ideas can be exchanged, shared, and new learnings can be done. They were supported by seniors like Dr. Chako, Dr. Taraporwala, and Dr. Sriram. Dr. Johari popularized the idea of POSI amongst his orthopedic colleagues, and Dr. Benjamin worked on the logo. The first inaugural meeting of POSI was held in 1994 at Bombay Hospital in Mumbai, and it was attended by stalwarts like Dr. Mullah Feroz, Dr. Dholakia, Dr. B. Mukhopadhyay, and the then President of Indian Orthopedic Association, Dr. R.L. Mittal. And finally, this was the time when Paediatric Orthopedic Society of India that came into existence. The first president was Dr. V. Chako, the first vice president was Dr. J.C. Taraporwala, and the first secretary was Professor Ashok Johari. Since then, in the very first year, the POSI crossed 200 members were already there in the very first year. The first annual conference was held in Manipal and faculty was invited from UK, New Zealand and South Korea. And every year the POSICON is held regularly. The sixth POSICON was a landmark POSICON which was held in Mumbai. It was attended by Professor Sutherland, Professor K. Wilkins and Professor Wenger. And this was the time when actually the POSI-POSNA alliance was, the seeds of that alliance were laid down during this conference. The POSI logo was designed by Dr. Benjamin Joseph. The logo has a Ashok Chakra in the background, which signifies that this is an Indian society. The Nicholas Andrew tree signifies that it is an orthopedic society, and the girl child with a hand-knee gait signifies the commitment of this society to eradicate polio. POSI-POSNA allowance was an initiative by Dr. K.E. Wilkins as a part of the POSNA core outreach program. The goals were to exchange information, to enhance the postgraduate training in this subspecialty, to facilitate social and cultural interactions. The first coordinator of POSNA was Dr. Sanjeev Sabharwal. Dr. Vrisha Madhuri was the coordinator between 2006 to 2012. And the first POSNA workshop, POSI-POSNA workshop was held in 2006 at Vellore, and it is a regular feature now. And fellowships and observerships are being offered to Indian surgeons in North America. And now POSI has successfully partnered with Paediatric Orthopedic Society of Pakistan, Bangladesh and Orthopedic Societies of Sri Lanka and Nepal. So this was the journey right from a time when orthopedics was unheard of, and slowly, gradually, with the efforts of these great surgeons, these great doctors, the subspecialty of pediatric orthopedics started to be recognized and POSI was formed. KGMU in northern India, KGMU took the lead and established a separate department of pediatric orthopedics. This department is actually a very vibrant department, carrying out many activities at a time. So it all started with establishing an independent pediatric orthopedic unit in the year 2008 with 2 days per week OPD and 25 beds. A grant was received from the government to meet the expenses. In 2016, NMC was approached for creation of a separate department, which was approved by MCI in 2018, and in 2018-19 the department was created with Professor Ajay Singh as its officiating head, and in 2021 separate department with full staff and Professor Ajay Singh was shifted from the orthopedics department to the Department of Pediatric Orthopedics. At present the department is offering MCH in pediatric orthopedics, which is indeed a great achievement, and in northern India this is the only institution which is actually training the postgraduates and providing super specialty training in pediatric orthopedics. Thank you very much for a patient learning, and I am sure that pediatric orthopedics is going to take the lead very soon, and with so many pediatric orthopedic surgeons being young surgeons being eager to join this subspecialty, this will definitely take a lead and all of you will help this becoming a super specialty of orthopedics. Thank you very much.
Thank you, sir. Indeed, it was a great and an inspirational talk. Now, I would like to invite Professor Nirmal Raj Gopinathan, sir, who is in charge of Pediatric Orthopedics Unit at PGI Chandigarh, to present his talk on future prospects and career in pediatric orthopedics. Laptop.
Thank you.
नहीं राहुल, इसको आगे करो ना, मेन पेज को आगे करो. चलो बाद में कर लो, पीछे के बाद में. आ गया.
Yeah. Good morning, everybody. Thank you, sir, for the excellent talk. I have made my job very easier. And first of all, it's my duty to thank the organizers for having me here. I am Nirmal Raj Gopinathan from PGH Chandigarh. And before going to the lecture, let's see how many of you, like I know many of you are MCH in Paediatric Orthopedics. Do we have a MS postgraduate here in Orthopedics? No? So we are not going to impress anyone to take up Pediatric Orthopedics here. So the duty is to make you guys stay in Pediatric Orthopedics. Huh? Okay. मैंने कुछ हिला दिया क्या?
हाँ सर, कीबोर्ड डिस्कनेक्ट हो गया.
अच्छा, ठीक है. Yeah, I again thank the organizers for having me here on this prestigious occasion, and I have nothing to disclose. So what am I going to talk about? So why need a specialization? Dr. Najmul took us through it very excellently after MS Orthopedics, and why Pediatric Orthopedics amongst all. It was also discussed in a manner. How to choose a type of and place for training, maybe that may be relevant for you guys, and what's the future prospects and career options. That's the most common question I come across with these trainees who has taken up MCH or fellowship in Pediatric Orthopedics. And we also have the other side of anything, so we can just go through them, and that can be like worked upon. So why need a specialization after MS Orthopedics? So as I was telling to others, so when I joined Orthopedics, I was congratulated saying that it's an end specialty. You're not going to give another examination or go for further training. But it's not the same. When I was doing my MS Orthopedics, I realized that there is something more I have to do actually. It's not going to end here. So this is what the life cycle of an orthopedic surgeon is being imagined by everyone actually. So it starts here and it rotates like this, and we think that it ends here actually. It's very simple, but it's not the thing. So to reach here, you have to go through a lot of training and specialization, and it doesn't stop with MS Orthopedics actually. So this is a paper by Dr. Pankaj, who is the HOD of the AIIMS Rishikesh, and he has written about the dawn of super specialty in orthopedics. So what are the points in pursuit of a resident's point of view? Why do an extra training actually? So the desire for an extra training in an area of interest. So as a postgraduate, you would have rotated across various specialties of orthopedics like arthroplasty, scopy, pediatric orthopedics, spine, tumor, etc. And you would have developed an area of interest actually. So we want to specialize ourselves in the area of interest by having extra training so that we are better at that job actually. And also we think that this is going to help us find better job opportunities or placement opportunities from an economic point of view also actually. So this data, we don't have a data in our country. In Canada, the employment opportunities for super specialty trained orthopedicians increased by 325% in the last 2 decades. And like in India also, we will be having this scenario. So it's super specialty training is a must actually. And in the parents' point of view, because we are talking about kids actually, so why there is a need for super specialization? There is a general preference for specialized services, especially in the urban middle class actually, which is percolating into other areas also. And also, initially people had to go to metros for getting these special services or specialized care, but if that is available in other places also, that is going to reduce the financial implications of services among the rural population. And the other point, talking about the evidence accumulation and research, so you can see that most of the publications or research that is happened through people who are having focused training, focused practice actually, not by general orthopedic surgeon, but mainly by a person. So arthroplasty research mostly is done by the people who are especially practicing arthroplasty, like pediatric orthopedics. We have the maximum number of publications with focused practice. So why pediatric orthopedics, as it was also dealt by Dr. Najmul. So it is a call actually. So this is the Japanese ikigai, where there is a thing that what you love actually. When you rotate among the different specialties in orthopedics, you would have developed an interest based upon the cases you see or based upon your mentor, how he handles things actually. So whatever impresses you, you are going to get trained in it actually, and you are going to be good at it. And also, we should not forget the monetary point of view also, and also what the society needs from you. So as it was put forward by Dr. Najmul, that 25% of the population in India is less than 18 years of age actually. It's a huge volume of population, and we have to cater them, and we have to address the issues. So if you see the kids suffering with cerebral palsy, the number is increasing now actually, because we are able to salvage every child who is born with other disorders. So these kids need special care, and they need a specialized trained pediatric orthopedic surgeon. And this was the slide we are talking about. 18%, 25% of the population in India is less than 18 years of age actually. And as Dr. Najmul was saying, kids are not small adults actually. They need specialized care. Their physiology is different. They have growth plates. They have a different pathogenesis for disorders actually. And you need special training while managing these kids. The other thing, how to choose a type of training and a place for training actually. So we have different specialities, courses being run here, fellowships, MCH, and there are different places actually. So choosing a place of training, you guys have already chosen it based on the mentorship. This is very important. You have to see a person who is heading the department, who is able to demonstrate a good amount of skill in managing these kids actually, so that you are able to be molded in a good way actually, based on the exposure that a student desires to attain. So for example, in KGMU, I can vouch that you will be seeing all conditions in pediatric orthopedic disorders actually, be it congenital, be it acquired, or like anything. So be it the neglected trauma, the late presenters actually. So if you want to be exposed to all the disorders in pediatric orthopedics, you should choose a center which is catering all these conditions actually. And also the credibility. Now there is NMC, and you have the courses offered by INISET actually, that gives courses in AIMS, PGI and JIPMA, or through NEET super specialty examinations. And also you have courses that fellowships that is being accredited by the Paediatric Orthopedic Society of India. We also have overseas fellowships. I have put it on one side actually. There is a craze to go for overseas fellowships. It's not wrong, but in India itself, you have very good places offering good amount of fellowship, like KGMU. We do give fellowships. AIMS gives fellowships actually, and MCH courses. So I think there is a lot of things to learn from India itself, and a lot of resources here, good mentors, good teachers here. Overseas fellowships, you can go for them as an addition to whatever training you are getting here in this part of the world. So there is also a difference between the fellowship given by private sectors, the fellowships given here, the government sectors, and the MCH program. We know that the duration is 3 years for MCH, whereas the duration for fellowships may be 1 or 2 years actually. But the most important thing is fellowships, it's based on the lead practitioner in a private sector. So they may be specialized in particular area of pediatric orthopedics, and you will be exposed to those particular area. Whereas in teaching centers, you have a wide variety of disorders being catered, and you will be able to expose to all of these things actually. And also in these teaching institutes, you have multiple departments working in tandem actually. For example, if you have a metabolic disorder, you can manage in coherence with the pediatric department. Endocrinology department, you can work together. Like a genetic department, you can work together. So there is a lot of scope when you are doing the MCH courses like here in KGMU, where you have a lot of potential. And future placement is the most important question being asked actually, as we were talking again and again actually. So 25% of the population are kids actually. So we have a lot of demand for a trained pediatric orthopedic surgeon. So you need not think that being trained in pediatric orthopedics I will not be able to survive. It's not like that. You guys have taken a right decision, and I want you guys to stick with that, and you will be able to practice in par with your other colleagues who are doing other things actually. So you are taking pediatric orthopedics by passion actually. You want to have a touch on the kids' health, which is going to reflect on the family also. So I think we have a very good future for trained pediatric orthopedic surgeons in India actually. And the children's hospital model. So now even the pediatric orthopedics is getting super specialized. So for example, there is a group of people who will be doing scoliosis surgeries, there will be a group of people who will be doing hip preservation, people working on congenital disorders, foot and ankle. So this is going to expand, it's not going to shrink actually, and this model is going to come everywhere. So there is a good amount of scope for you guys actually. Yeah, MCH, you have limited seats, the center selection is not in your hands, it's based on rank, and some people think that it's a long duration for doing a pediatric orthopedic specialization, but believe me, even 3 years is not enough, even 30 years is not enough for learning pediatric orthopedics. You're going to learn every day actually, and 3 years is a good amount of time invested in doing a pediatric orthopedic training. And future prospects and career options, I touched upon it in this previous slide itself. Doctors with specialty is going to be in demand after at least for 2 to 3 decades. I can vouch for that actually. So you need not worry about that. And so you have around 26 AIMS-like institutes. You have a lot of postgraduate institutes, and all of them, as Dr. Najmul was saying, that we have a separate pediatric orthopedic unit, but when we are going to expand and form a department, all of you are going to be in demand actually for establishing and running those departments actually. So job wise, opportunity, monetary wise, I don't think there is going to be an issue when you are going to be trained in pediatric orthopedics. And the children's hospital model is going to pick up. So hip preservation, neuromuscular disorders, scoliosis and spine surgeries, foot and ankle deformities, trauma, sports medicine, name it, it's going to expand in a huge way in the coming decades actually. So definitely you guys are having a lot of things to work upon, and it's with a lot of scope actually. The other side, we always discuss about the other side also. So it's considered to be an overqualification by some. People think that if you are trained in pediatric orthopedics, you may not be able to secure jobs in a general orthopedic department. But I think, as I told you, the pediatric orthopedics is going to branch out, and I don't think that should be an issue for at least next 3-4 decades actually. There is a question of survival practicing only pediatric orthopedics, and even many of the MCH candidates were also asking the same question. And also, as I told you, you have a lot of scope in pediatric orthopedics, so that should not be an issue actually. And we also saw that the children's hospital model is going to pick up, and so we believe that this is going to expand more rather than it's not going to shrink, and there should be a lot of opportunities. So I stop it here. So if you have anything to interact, we can do that actually, then we can go for some cases actually, so that we can have, if you have any doubts, you can just ask us regarding your future or placements. Dr. Najmul is here.
So I think you were very right in saying that I have so what I think that you were very right in saying, the branch of pediatric orthopedics will actually expand. As sir has very rightly said, that there will be sub-speciality in this super speciality. People doing exclusively scoli, people exclusively going for hip preservation surgeries, sports injuries in adolescents, pediatric age group. So this is going to expand, and the demand of pediatric orthopedics is definitely going to increase further, because there will be many more government institutions who will be following suit, who will be following KGMU and other INIs to develop exclusive pediatric orthopedic departments. And you being a trained MCH student in that, you will be easily absorbed in these institutions. So I think the future holds really good for all of you, and I always motivate my students, my postgraduate students, to take up this branch of orthopedics. This is still a virgin area. Arthroplasty, arthroscopy saturated है. इतने arthroplasty surgeon, अब arthroplasty is being done at every hospital. You name it, and a knee replacement surgeon is already there. So this is still a virgin field, and actually much needs to be done. These children need us. They need specialized, trained pediatric orthopedic surgeons.
Thank you, sir. So we can move for some cases. Actually, I have some 6 cases with me, just to keep your interest. So the first one is a 15-year-old female. She presented with a deformity of the right lower limb, difficulty in walking, and because of this cosmetic deformation and difficulty, she is restricted in house due to, and she is not attending any school, or like she is not going outside actually. So the history is at 11 years, that is 4 years before presentation, she had necrotizing fasciitis. She underwent fasciotomy, the wound got infected, she developed an osteomyelitis of the proximal tibia and a pathological fracture. She underwent multiple debridements and a flap cover was done, but she had a progressive deformation. So this is the clinical picture, the non-weight bearing clinical appearance actually. There is a 45 degrees of proximal tibial varus angulation, and there is a 5.5 centimeters of limb length discrepancy. So this is the gait. So because of this, she is like not going out anywhere. She is a 15-year-old girl, and she must be in school at this age, but she is just in her home. So this is the radiograph. This is the best radiograph I was able to pull out. So here you have a pointer. I think my cursor is seen. Yeah. So you can see that there is a pathological fracture along with the non-union here in the proximal tibia. The bone quality is pretty poor. There is a varus angulation in the proximal tibia. Okay. And you also saw the skin condition with the flap covered, and this is the scanogram. So these are the things that are to be addressed: the proximal tibial pathological fracture, non-union, the poor skin condition, 45 degrees of varus and 5.5 centimeters of shortening. And what I did was, this was like at least some 12 years back, like when I started my practice. So I did an Elizero, the standard one. It's not something new actually. We all do that. So I did a deformity correction and docking at the proximal site, and I also did a corticotomy at the distal site actually. And we were able to get around 4.5 centimeters of lengthening for her. And this is the follow-up radiograph actually, the post-op radiograph, and this is the pre-op for comparison actually. So we were able to get a good union as well as length in this kid, and this is the post-operative gait. So it's not a big job, but it creates a lot of change in the patient's perspective, as well as it adds value to the family also actually. They were very happy, and at the end of the day you can make a difference actually as a pediatric orthopedic surgeon. You can touch upon the lives of not only the child actually, but the entire family, like who are all apprehensive about the kid actually. So she had good outcome, good function. She was able to squat, sit cross-legged, and she started going back to school again actually. So the second case is a 4-year-old girl, and she has history of abnormal positioning of both the lower limbs since birth, underwent casting few times followed by a probable tender Achilles tenotomy. She had normal milestones, started sitting at 6 months of age. She has flexion deformity of both the knees, so she cannot stand up, but she is walking on her knees since 1 year of age. There is poor eyesight on the left side, and again this kid is restricted to home because this is how she ambulates. So either she is able to crawl or she is able to walk on her knees actually. So there is a clinical picture. You can see the amount of flexion deformity. The callosity is here, meaning by she is bearing weight only on the anterior aspect of knee, and the knee is like has 90 degrees of flexion deformity, further flexion of around 30 degrees. The ankle is also in equinus deformation of 10 degrees, and she has an Escobar multiple pterygium syndrome. So there are many ways of addressing a flexion deformity in these kids actually. Some of them go for Elizarov frame assisted distraction with or without release actually. So what I do is we do a CT angiogram just to look for the vessels actually here, but I do combine with the plastic surgeon. So that's again thing what I was talking about, institutes like or centers where you have multiple specialties, you can have a team actually with you. So here my plastic surgeon does a Z-plasty of the web, they expose it, and we go for soft tissue release. We do an extensive soft tissue release of the posterior aspect, including a capsulotomy as well as a partial PCL release actually, okay, preserving the neurovascular structure, and also we do a shortening extension osteotomy of the distal femur. So this is what we were able to achieve on table. This is the fixation, and this is the immediate post-operative picture from where 92 we were able to reduce the flexion deformity to around 30 degrees. So after this we do wedge casting and get complete extension of the lower limb. So this is operated one side with the heel wound, and this is the gait after she is getting after she was operated for her left lower limb. The kid underwent the same surgery on the other side also, and this is the follow-up. Now she is able to stand on her foot and she is having a bipedal gait actually. She is using braces, but she is able to walk with bipedal gait. These are the follow-up radiographs, and so now you can make a lot of difference actually, but we put a lot of science into it, but definitely we are able to have kids back on their foot. And this definitely is going to change a lot of perception for the kid as well as the family. Any doubts? You want to ask anything? Suresh, any comments? Faisal?
Sir, this is an excellent demonstration, and I mean good teamwork with the plastic surgeons. So we are doing such cases in a different way. Just do the distal femoral extension osteotomy. And we have used anterior 8 plates also. Okay. Although we don't have such long follow-up, but I hope to see similar outcome with the probably less intensive surgery.
Intensive surgery. Okay.
Although the outcome is very good, and
great.
Definitely difference has been made.
Okay.
In such cases, I think avoid so much soft tissue resection. Without soft tissue resection, what are the other options?
Yeah, if you go through papers by Harold Van Bos, so he combines a soft tissue release with a fixator. So I have done it, but the problem with these kids, orthogrypotic kids, their soft tissues are not as stretchable as other pathologies or other kids actually. So invariably I saw complications like fractures or like pin cutout, etc. So this may look gore actually, but you can see the healing. This healing happens within 14 days actually. The entire thing comes off within 14 days. So now I have around 11 to 12 knees. In one of them I had a bit of soft tissue issues, healing issues, but it settles down actually. I know it looks a lot invasive actually, but if you don't want to do that, you can combine the soft tissue release along with the distractor, with the frame actually. So Herald does a limited soft tissue release along with the frame actually, you can do that. And anterior plates, like if you have, so you can grade these deformations into mild, moderate and severe. And if you have a deformation less than 30 degrees, the anterior plates can work. If for severe deformities, you need a long duration for the anterior plates to work actually. So that can also be combined. You do some limited soft tissue release, distract, put an anterior plate actually. So this is not going to stay the same actually. So when the child is going to gain height, the soft tissues are again not going to expand and she is going to develop a flexion contracture again. So at that point of time, I will be using an anterior plate actually for her. Okay. Oh, you also have to interact, guys. So it's like so everybody will. I also will go to sleep actually. It's not that you will go to sleep, huh? Yeah. So third case, again one of my favorite cases for showing. Yeah, you can say that like for flexing. So this is a case who came to me like this actually. So he's a 14-year-old male who is a known case of polyostotic fibrous dysplasia. The child had craniofacial lesions, pelvic lesions as well as in the left femur. So these are the x-rays I was able to pull out from him. So here you have a lesion in the entire femur. The entire femur is affected and you can see that there is an impending pathological fracture. So the patient presented to the center with progressive deformation as well as difficulty in walking. He was subjected to osteotomy, deformity correction and stabilization with a 12-hole plate. So this is how it was done previously. So yeah, like we can have comments like this is not done by me, but so I can happily take comments.
So for a pathological bone, probably not the ideal way of fixation.
Yeah, exactly. For a pathological bone like this is not ideal, and you can see that the lesion is extending more or distally actually. So neither the lesion is spanned nor this implant is adequate for this one. So what was said by Dr. Suresh is happening. So there is lysis around the screw ends, the plate is pulling out and there is progression of the deformation. There is more varus actually. And to add to that, the patient had a fall and you can see that there is a fracture that has happened again distal to the plate actually. So what did the surgeon do? So he gave some zoledronate in between and it was revised to a longer plate. So Suresh?
So I don't know, maybe again.
I have shown the end result there itself. So
a nail would have been better.
Exactly.
So
in a pathological bone in fibrous dysplasia, the best implant is a nail actually if you are able to use it. Okay. So again, it failed, the plate was taken out and then he was referred to me actually. So what are the issues? There is definitely a pathological fracture of the neck. Also there is an ongoing avascular necrosis of the proximal femur. So how we are going to manage it? So I am a fan of angle blade plate and fibula grafting because I am from PGH Chandigarh. So we use a lot of it actually. So I the most common implant I use in ABP everywhere actually. So we are going to address the biology as well as the pathology and the biomechanics actually. So what we thought is, I can convert the shear into a compression by doing so in between. Nail is the most appropriate implant actually, but for this case I thought I will not be able to nail him at this point of time. I need a more aligned femur. So what I did is I used a ABP as I told you. So this is how the blade was put inside and this was how the fibula was put inside actually. And I did an osteotomy to correct the alignment also, and this is how it went. So we were able to get a good biomechanics here. We were able to bridge across the pathological fracture, and I used bisphosphonate later after healing to keep the graft in place. Otherwise in fibrous dysplasia, whatever graft you are going to use, it's going to resorb actually. So this is an intralesional bisphosphonate, and this guy went on to do well actually. I still have his follow-up, and see, this is how it came out. So he has an excellent reformation of the neck as well as function. So now I counsel him to for a nailing. I tell him that I will take out the plate and put a nail inside. So he says, I don't have any issue, I am not going to get another surgery done. So this is how he is functional, and his modified Harris score is 98 out of 100. So as it was discussed, the implant should be chosen prudently according to the pathology, and we do use bisphosphonates to avoid graft resorption in these lesions actually. Any comments?
So
Yeah.
So what is your protocol for bisphosphonates in fibrous dysplasia patients?
Yeah, once the osteotomy heals, I give them, what I do is I try to give them part of them intralesional, because at many times it may not diffuse inside the bone actually. You calculate 0.025 into the body weight actually, half of it being given intralesional and half given intravenously. And this is given every year actually. So I give them at least three doses for these patients for 3 years actually.
Sir, the lesion is extending so long, so
Yeah.
which lesion to target with zoledronic?
So the intravenous dosage what you are giving is going to target the entire bone actually. The local graft was my concern actually, so I was giving the intralesional there.
Okay, intralesional at the graft only.
Yeah. If you have a localized lesion, you can target it. If you have a lesion that extends through the entire bone, it's not feasible actually. So the intravenous one has to take control of that.
So like sir, in CPT we are using it pre-operatively.
Yeah.
So
The bone healing part, isn't it? You are asking.
no, I mean what we do is we give it 6 weeks before the actual planned surgery, so that the zoledronic is inside the graft, which is to be taken out.
Yeah. For this patient, the surgeon himself gave a dose of zoledronate actually.
Okay.
So it was given beforehand also actually. So you are right. You want the drug to be in the fibula actually, isn't it? Yeah. That happened to this patient actually itself.
So sir, routinely do you also give injection zoledronic pre-operatively in fibrous dysplasia patients also? Because the main motive is about the graft.
The graft. So with the accumulating evidence now, it can be done actually. For CPT, as he was saying, Pali usually gives zoledronate before surgery actually for the drug to get into the fibula actually. So you can do that actually.
Sir, is there any role of prophylactic nailing in this case primarily? When the patient was presented in the first
Yeah, nail is the best implant. Nail is that's a paper also I shown you actually. You should have a nail, cephalomedullary nail with a hole in the neck actually. You should have a neck screw. So it can be something like a recon nail or
Recon nail
anything.
type
Yeah,
something.
that's the best
So
implant.
we can add, we can use this recon nail as a prophylactic measure
Yeah.
in such cases.
If you have a proximal femoral fibrous dysplasia with a
Yes.
minimal varus, you do an osteotomy and insert a nail inside actually.
Okay, sir.
Okay. Before it progresses and goes to a pathological fracture.
Okay, sir.
So I think sir, we are having 5 minutes after that.
Okay, great. So you want me to run? Like we have 3 more cases actually, you can do that. So there is another 17-year-old male, who has pain on the right side of hip and difficulty using right lower limb, had been operated 18 months back for a fracture neck femur, and you can see that this is not adequate reduction actually. This is not how it should not be done actually. So neither the fracture is reduced, nor the screws are spread out, nor the screw is taking adequate purchase. So this is bound to fail. Okay, and failed, and you have a pathological, a non-union at the fracture site. The screws are sticking out of the femoral head into the joint, as well as you can see that there are density changes and avascular necrosis. So this is the CT and MRI, and how many of you would like to salvage this? Can we salvage? Faisal is for salvage. So what do you want to do, Faisal?
So I think we can go for the screw removal, and we can go for a valgus intertrochanteric osteotomy, and we can put fibula graft.
So good. Did you see the case before? Huh? No? Good. Yeah, that's what was done actually. You can see that there is a good amount of cartilage or a femoral head here down actually. So this presents to our orthoplasty surgeon directly is going to replace it actually. But we are like, we want to salvage everything. We don't want orthoplasty in a child. Okay, in a 17-year-old it's not justified. So you have to gain years for this hip. You have to preserve it. So just skip it. So my favorite implant, as I told you, is an ABP along with the fibula for the non-union. So I just went on with it, did a valgus and a fibula stud insertion, and this is how it went on to unite as well as his function. He is doing well. He is not even coming for a follow-up. I am just had to call him. He is not coming. So yeah, you can do a lot of things if you respect the biology and biomechanics. Just to rush through the other two cases, a 9-year-old female fall from an, you can stop me whenever it is time actually.
So you can finish the cases.
Okay, there is a fall from height on outstretched hand 4 months back. So this is why like the availability of facilities and the trained eyes to see x-rays to catch up the pathology in the remote areas, like they have to come to centers like this to get treated. So if you guys are trained and available, like the service available, these kids will be benefited actually. The child was managed non-operatively, has a painful stiff elbow, and this was the radiograph which was said that it is normal. But if you look carefully, you can see that you are not able to see the radial head here. There is a proximal ulnar malunion here, and see this is the radial head. You can see it end on. So this is the proper image which has to be done, and here there is the radial head here, there is a fracture at the radial neck, there is an ulnar malunion, and this is a type 2 Montegia variant. Just to be fast, so this is a type 2 Montegia variant, and it's a painful stiff elbow. So we thought we will go for a surgery, and the direction of ulnar, the fracture ulnar, it is the main factor that decides what are you going to do in these kids. So guys, you have to plan every case actually. I would like you to do a paper cutting first, then you go for your software, Bone Ninja, whatever you have actually. Take trace in a paper, cut it, do your osteotomy beforehand like this. So this is how I did. So we did the osteotomy to see whether the radius translates anteriorly after doing an ulnar osteotomy, and this is how it was replicated on table. So I used this monolateral frame to do the ulnar osteotomy in a minimally invasive way, and this is how the radial head was secured. This is the immediate function. The radial head goes for avascular necrosis, but it has very good prognosis compared to femoral head. Okay, this went on to unite well, and this is the function after a long follow-up. So she is doing good. She has a very good function actually, but the thing is, these things are missed actually if you don't have the trained eyes to pick them up earlier actually. So you have to be vigilant, and the ulnar fracture character is more important than the direction of radial head dislocation. The last case, this is also just not to forget what's important. A 17-year-old girl with a hypophosphatemic rickets with a gross deformation. So she has shortening as well as deformation. She wanted to have a correction of deformation as well as length. So these are the metabolic parameters. So we underwent an osteotomy, correction of deformity along with an LRS application to lengthen actually. So this is done in, you can see it in May. And these are the follow-ups, the distraction, and it was stopped, and this is almost 6 months after distraction. You're not seeing anything. What do you think, Suresh? What went wrong?
I think the deformity was corrected acutely, then lengthened. Probably that made the regenerate poor.
There is a poor regenerate. Faisal? So she is a hypophosphatemic rickets patient.
Sir, I think we could have given some, intravenous maybe bisphosphonates before proceeding for surgery for a good regenerate. Maybe that
Okay.
could be a reason.
Yeah. So I did a blood workup actually, and this is the phosphate level. It's 1.2. So for a normal mineralization, you need both calcium and phosphate actually. For hypophosphatemic rickets, it's very important. So I was like not giving attention to the phosphate level actually. So I took help of my endocrinologist. I believe that there is regenerate, but I'm not able to see it actually. So you can do an ultrasound. I did an ultrasound. I was able to see a bridge. Okay. So I called my endocrinologist and I asked him, so something is not right here. Can you do something? So he gave phosphorus supplementation and see what's happening. Just within a month, you're seeing that it's getting lighted up. And this is like, it has mineralized now. So then I went into literature and I saw that this happens actually. So there is a H index, healing index, which is the duration of external fixator divided by the length gain. Like if your consolidates well actually, you need not have the fixator for a long duration. So usually it is 1.5, but for our case it is like 3, double the time because of the phosphorus level actually. So those with serum phosphate level below 2.5, they had a healing index of 3 actually. Yeah. So do not neglect the phosphate level, and for planning for osteotomies and disc fracture, ensure that the phosphorus level is more than 2.5 milligram/%. So she had another fracture in the regenerate, and I had to nail her, and now she is doing well actually. The other side is also being operated. Yeah, just the last slide, guys. All of you, I would request you to register for POSICON actually. We have a lot of things to happen. Okay, thank you. निकाल दो.
Thank you, sir. Indeed, it was a wonderful presentation and very good case examples. So now I request everyone to for a short tea break. We'll be right back here at 11:30. So we'll take a quick tea break.
We will have Professor Ajay Singh's oration at 11:30. So I request all of you to be back in the auditorium in 5 to 10 minutes.